Ciao tutti, Jim Fanelli here, Wilmington, North Carolina, with another episode of the Tuscan Discussion, brought to you by CE in Italy and Europe. Check out our website, ceinitaly.com, for all of our upcoming venues. Today's Tuscan Discussion, we're going to have a topic of retinal vein occlusions. Now, as you know, retinal vein occlusions come in a variety of different formats. We can have a central retinal vein occlusion. We can have a hemispheric retinal vein occlusion. We can have a branch retinal vein occlusion. But all retinal vein occlusions have similar characteristics insofar as the etiology. And as you also know, they are a manifestation invariably of some type of systemic disorder. And it is incumbent upon us to find out what the cause of that systemic disorder is. The majority of patients with vein occlusions, especially branch vein occlusions, do not have macular edema. Those individuals with branch vein occlusions or hemispheric vein occlusions or central vein occlusions that do in fact have macular edema would benefit from anti-VEGF therapy. And those folks are ultimately going to need to be in the hands of a retinologist to administer the anti-VEGF therapy. However, treating the macular edema is only a part of the process. Again, this whole vein occlusion event is a manifestation of an underlying systemic disease. So before we begin treatment of the macular edema, we need to get to the root cause of the problem. And that's what I want to talk with you about, because the workup of patients with vein occlusions is certainly within the wheelhouse of optometry. So the basic question is, in all vein occlusions, what's the underlying pathophysiology? Now, I know a lot of you are going to immediately default to hypertension. Keep in mind, hypertension causes structural changes in the arterial system. Of course, retinal vein occlusions is an occlusive disease that occurs in the venular system. So the venular system is not directly affected by hypertension like the arterial system is. But as you know, the retinal artery and the retinal vein system lie in close proximity to each other in the retina. We have arteries taking blood into the retina. They fan out from the central retinal artery, primarily along the superior and inferior temporal arcades. Those capillaries that are fed by those arteries begin to join. They form the retinal venular system, and all that blood is ultimately heading back toward the optic nerve. But in the course of the retinal vasculature, more often than not, retinal arteries lie on top of retinal veins. And keep in mind the histology of retinal arteries. Their walls are elastin. There's smooth muscle fiber in these walls, so they are much more prone to adaptation due to structural pressure differences such as what we see in hypertension. Venular walls are much more flaccid, so think of a venular wall as being very, very soft and susceptible to compression by a harder walled retinal artery, which most of the time lays on top of those retinal veins. When we have a retinal vein occlusion, whether this is a central retinal vein occlusion, whether this is a branch retinal vein occlusion, or whether this is a hemispheric vein occlusion, there is a thrombus that forms in that vein. And that thrombus that forms is what causes further narrowing of that vein, and therefore a backlog of blood behind that thrombus. The question is, what is causing that thrombus? For example, in patients who have hypertension or elevated cholesterol or diabetes, or the 5 main risk factors for atherosclerosis: diabetes, high blood pressure, elevated cholesterol, smoking, and obesity. These individuals undergo structural changes in the arterial system, and those structural changes in the arterial system begin to compress and press on and distort the exterior wall of the venular system. So that vein that was normally flaccid but tubular now has a distinct compression in it. And it is that compression in the vein that is not completely closed off, okay? It's just narrowed down, but that narrowing of that venule causes the blood flow through it to become slower and perhaps a little bit turbulent, and that sets the stage for a clot formation. That's the thrombus. So retinal vein occlusions oftentimes come from a thrombus, more often than not at an artery vein crossing, whether that's in the retina or behind the lamina in the optic nerve. But because of this thrombus formation, this venule that used to be like this is now somewhat depressed, flattened. Part of it is now occluded with the thrombus. That vein still has blood flow through it because we know that blood is still getting into the eye. The eye is still functioning. It's malfunctioning, but it's still functioning. That blood is getting into the eye. It's just having a hard time draining from the eye because that venule now has been compromised and partially occluded with the thrombus. What ultimately is causing the thrombus? Therein lies the question. In those individuals who have atherosclerosis, hardening of the arteries, development of atheromatous plaques in the lining of the arterial walls, if we see a vein occlusion with some compression and perhaps AV crossing changes in other areas of the retina, chances are very high that what caused that vein occlusion is an artery compressing that venule, and then, because of that compression, a thrombus forming. So one of the more common causes of all forms of vein occlusions is atherosclerosis. And keep in mind, the atherosclerosis is affecting the arterial end of the system, and the structural changes that occur in the arterial end of the system are compressing and causing secondary structural problems to the venular end of the equation. And the majority of our patients that are in their 50s and 60s and 70s who present with retinal vein occlusions typically have as the underlying cause elevated blood pressure, elevated cholesterol, diabetes, hypertension, smoking, obesity, etc. Those types of things. But what happens in an individual, for example, who is younger, who presents with a vein occlusion, who doesn't have any overt signs of atherosclerosis? There's no findings in the retinal tree. We have this wonderful retinal tree to examine all these crossing changes, both the right and left eye, for signs of atherosclerosis. But when we don't see atherosclerosis, which would be certainly a contributing factor for certain vein occlusions, when we don't see the atherosclerotic changes, but we see a retinal vein occlusion, the question then is, well, what in the world is causing that vein occlusion? It still goes back to a thrombus forming, and that thrombus could be forming in a branch retinal vein, a hemispheric retinal vein, or the central retinal vein. But what can cause a thrombus in an otherwise healthy individual? If we see that, if we see a retinal vein occlusion without the associated atherosclerosis, we need to then start thinking about the possibility of hypercoagulable syndromes that are inducing clotting in this individual. And those hypercoagulable syndromes can fall primarily into two categories. One is antiphospholipid antibody syndrome. It goes by a couple of different terminologies: anticardiolipin antibody syndrome, and that's typically, I call it antiphospholipid antibody syndrome. This is an autoimmune disorders whereby certain antibodies, in particular anticardiolipin antibodies, are produced, and these anticardiolipin antibodies increase coagulability in these individuals. And these coagulabilities and these thrombi can form in both the arterial system and the venular system. So if you have a young lady, for example, who presents with a vein occlusion, one of the things we need to think about is antiphospholipid antibody syndrome, especially if this young individual has had a history of miscarriages, because oftentimes antiphospholipid antibody syndrome is undiagnosed, and that may be the ultimate cause, certainly, of the miscarriages and certainly of the retinal vein occlusions. Another condition that can cause retinal vein occlusions is a genetic condition called factor V Leiden. This is an inherited autosomal dominant condition whereby these individuals just are prone to coagulation. So in the context of retinal vein occlusions, you have an otherwise healthy individual with no overt retinal signs of atherosclerosis. Factor V Leiden may ultimately be the culprit. And this is typically found in individuals of European descent. So, how do we manage these individuals? And I'm going to simplify this into those vein occlusions caused by atherosclerosis versus those caused by hypercoagulable syndromes. For individuals who have hypercoagulability, the standard labs include a CBC with differential. For example, things like sickle cell anemia can also cause vein occlusions. And a CBC with differential is an elegant, simple test that's going to pick up 90% of hematologic disorders. But if we have an individual who doesn't have the atherosclerotic changes in the presence of a retinal vein occlusion, antiphospholipid antibody syndrome needs to be considered, and that's going to be done, or that's going to be established lab-wise with an ELISA test. And then the factor V Leiden, labs, genetic labs, are going to ultimately be determined by the individual lab provider that you're using. So CBC with the coagulable labs are in order for those individuals. For individuals who have atherosclerosis as the suspected underlying condition, they of course need to have their blood pressure checked and under good control. They need to have their lipid profile checked and under good control. And these are individuals who would probably benefit from a stratified lipid protocol. In other words, those subtype particle lipoproteins, in particular the bad LDL lipoproteins. So ASCVD, atherosclerotic cardiovascular disease, these individuals have retinal signs. They have probably disseminated vasculopathy throughout their body. So the risk factors for progressive atherosclerotic cardiovascular disease, again, are hypertension, diabetes, and elevated cholesterol. Those three things need to be well controlled in order for the vein occlusion to begin to resolve. Again, some vein occlusions are going to come with macular edema. Those folks need to go to retinology so that they can have anti-VEGF therapy. But for those individuals without macular edema, that's our job to find out what is out of kilter. Is it the patient's cholesterol level? Maybe they're on a blood pressure medicine, but maybe their blood pressure isn't quite as well controlled as it needs to be. Maybe they're on a statin, and maybe their lipids are not quite as well controlled as they need to be. Patients with atherosclerotic cardiovascular disease oftentimes have elevated homocysteine levels, so that certainly needs to be checked. So atherosclerosis can induce retinal vein occlusions due to structural changes in the arteries, secondarily affecting the venular system, and hypercoagulable states in younger, healthier individuals can also cause retinal vein occlusions. Hopefully you got a little snippet or two of information from this. Come join us with our CE in Italy programs in 2022. We are heading to Barcelona, Florence, the Greek Isles, Budapest, Prague, and of course, Tuscany. So again, challenge.